Hello, my name is Dr. Christine Sethna, and I'm the Division Chief of Pediatric Nephrology at Cohen Children's Medical Center at Northwell Health and the Associate Professor at the Feinstein Institutes for Medical Research in New York, the United States. And I'll be talking today about the possible role of transcutaneous auricular vagus nerve stimulation for the treatment of nephrotic syndrome in children. As many of you are aware, childhood nephrotic syndrome consists of the constellation of proteinuria, albuminuria, edema, and hyperlipidemia. Although the incidence is fairly rare, it occurs between 2 and 7 per 100,000 children, it takes a considerable toll on our healthcare system, consisting of 12% of all pediatric kidney transplants in the United States. And the most common diagnoses are minimal change disease, followed by focal segmental glomerular sclerosis. The mainstay of treatment are steroids. However, steroids have a lot of side effects, such as immune suppression, poor growth, weight gain, problems with the blood pressure, and some children still don't respond to steroids or become frequent relapsers and then become exposed to multiple other steroid-sparing medications, such as MMF, tacrolimus, rituximab, and Cytoxan. As you can see, all of those also have their own adverse side effect profile. So it's of utmost importance for us to try to find medications that are safer and have less side effects for our children. However, the difficulty in finding treatments is that the pathogenesis of nephrotic syndrome is not entirely known. Multiple studies have shown that there are abnormal T cells, cytokines are elevated, and there may be circulating antibodies that also may affect and cause nephrotic syndrome. So looking towards different ways to affect the immune system, we're going to start talking about the inflammatory reflex. And this was coined and discovered over 20 years ago by Dr. Kevin Tracy at our institution here, who found that inflammatory stimuli through the vagus nerve went to the brain, to the nucleus tractus solitarius, and affected the immune system through two different pathways. One is by stimulating the hypothalamus to secrete ACTH, which goes to the adrenal glands and suppresses peripheral inflammation. And the other is termed as the CAP, which is a cholinergic anti-inflammatory pathway, which is the efferent vagus nerve leading to the spleen. And that causes acetylcholine release from these chat CD4 T cells. And when that is released, it leads to decreased cytokines and also inhibits B cell migration and antibody release. And the vagus nerve has been studied for a while now in treating disease processes. So stimulating the vagus nerve either through implanted vagus nerve stimulators or external use through transauricular vagus nerve in the ear has been used for multiple things. It's actually FDA approved in the United States to treat depression and seizures. However, more recently, there have been immune-mediated diseases that have been studied, such as IBD, rheumatoid arthritis, and lupus. So the question is there a role for the inflammatory reflex in the kidney? And there have been several mouse models that have looked at using vagus nerve stimulation to prevent acute kidney injury. And this group, Tanaka et al., actually mapped out the pathway, which included the CAP, stimulating the vagus nerve to reduce inflammation, which then led to decrease in the creatinine through the anti-inflammatory mechanisms. So the question then becomes, is this something that we can do for nephrotic syndrome? So we decided to test this out in a small pilot trial of 7 children. And this study was published earlier this year. Our inclusion criteria included children with frequent relapsing nephrotic syndrome who are in remission, those who are steroid resistant with minimal change or FSGS between the ages of 3 and 17 and a GFR greater than 30. And we excluded those with any inflammatory condition and implantable devices or who were pregnant. In addition, those with frequent relapsing nephrotic syndrome had to be off steroids for 14 days and on no other immunosuppression for 3 months prior. And if they had exposure to rituximab, their B cells had to be replete at the time of enrollment. For the steroid-resistant group, they could be on immunosuppression, but it had to be stable for 3 months and no changes could be made during that 6-month period. And their baseline urine protein creatinine ratio had to be greater than 1 for an average of 3 months. So this was an open label pilot study, and we used a TENS machine, which is actually a fairly cheap machine. It was $28 on Amazon. And our bioengineer created this ear electrode, which was placed on the left ear and put in the symbicontia, where there is an auricular branch of the vagus nerve. And we set the TENS unit at these settings, and the patients used it for 5 minutes per day for a total of 6 months. And because of the theoretical risk of bradycardia, we did monitor them with pulse oximeters and monitor their heart rate while they were on. So for the frequent relapsing group, we had 3 children ages 4 to 8, all of whom had 3 to 4 relapses in the previous year, and 2 of whom were on CellCept previously. And during the 6-month study period, they had no relapses. 2 of the patients decided to continue with the vagus nerve stimulation after, and they remained in remission for a long time, and actually almost 15 to 17 months after one of the patients stayed in complete remission, back-to-back infections, he did end up relapsing, but continues to be relapsing very infrequently. And the other patient continues to be in remission. And the patient who decided not to continue started relapsing again as soon as the vagus nerve stimulation was stopped. And then the steroid resistant group, we had 4 children, 3 of which had FSGS, and 1 was acting as our control who had a genetic form of congenital nephrotic syndrome. And as you can see, they were all in a stable regimen of immunosuppression and ACE inhibition. And over the time period of 6 months, there was a 25 to 76% reduction in protein in the FSGS group. And although there was a slight reduction in protein in the genetic person, that person still remained very nephrotic. I just want to highlight one of the patients in particular who started off with the UPC greater than 2 for over 2.5 years. And by the end of the 6 months, the UPC came down to 0.5. And then the mother was hospitalized for a month and they stopped the treatment. And then the UPC went back up to above 1. And then when the vagus nerve stimulator was started again, he was able to quickly get back down. But by the time that the study was published, he was back down to 0.5. Right after the study was published, he actually hit a complete remission at 0.2 at 23 months. In addition, we were able to show a concomitant decrease in TNF alpha, and this difference was significant amongst the group. And in terms of safety and feasibility, there were no adverse events, no reported side effects, and everyone who was approached enrolled, and there were no dropouts. There was one issue with an adolescent who was non-adherent for about a month, but overall the parents disagreed that the taVNS was burdensome, so they all actually preferred it over taking immunosuppression. So in this study, we found that taVNS was associated with clinical remission of frequent relapsing nephrotic syndrome, and it was also associated with moderate reduction in protein in steroid-resistant nephrotic syndrome. So we conclude that taVNS has the potential to provide a non-pharmacologic steroid-sparing option for the treatment of childhood nephrotic syndrome, and has the potential to avoid deleterious side effects of immunosuppressive medications. So this requires further study, which will be done in the next stage of a clinical trial. Thank you so much for your time.